we really appreciate the great questions that everyone contributed last module. We had a great discussion. We had lots of people stay online up to 30 minutes after the module ended, just exchanging questions and ideas. And we said that we were going to compile those and share those with all the participants. And we're still doing that. We're still working on that because we just had such great and thoughtful questions that we'll still be getting that to you in the coming days. So thank you for those great questions and keep them coming for this module. I just quickly wanted to discuss assignment 2. And you should have received in the email details of assignment 2 for those eager participants who wanted to go ahead and see what the assignment would be about. But for this assignment, there are 2 options. There's a case study of NTD WASH integration and collaboration. And there's also an option of interviewing with an NGO that works with NTDs or interviewing a ministry official from your country. So the first option is a case study where if your organization has previous or current experience with WASH or NTD integration, then we'd love for you to do this option. Or if you know about another organization in your country that has had successful or not successful integration of WASH and NTD. The case studies that we're asking you to do not have to have specific elements. It will vary depending on the context, depending on the story that you're trying to tell with this case study. So just to note again that the case study does not have to be a best practice. It doesn't have to be a success story. It could also be a story where challenges were identified or there were some issues with the collaboration or the integration of WASH and NTD programming. So this is the first option, and it might be a page or 2. Some people might have 3 pages, but we're just asking that people put some time and thought into this, and this will be due in 2 weeks. So the second option is an interview with an NGO personnel who works with NTDs or a ministry official. And the purpose of it is to identify and understand stakeholders' perspectives on potential ways to integrate NTD control with WASH. Also to assess stakeholder motivation for partnering and understand the arguments for collaboration and to identify the synergies across the sectors. So what we would ask you to hand in from this interview are the notes from your interview, a short description of who you met with, and what you learned from that interview. So it's due in 2 weeks when our next module takes place. And any questions or concerns, feel free to email me, as always, at the email shown here, kellytesh@gmail.com. So today I'm very excited to introduce you to Dr. Matt Freeman, who is an assistant professor environmental health at the Rollins School of Public Health at Emory University in Atlanta, Georgia. He has extensive experience in water and sanitation, and he has lots of experience working with partners all over the globe. He has a strong interest not only in working with NGOs for sharing and dissemination of the research, but also he's interested in collaborating with WASH practitioners in order to improve and shape research questions. Because many of you out there listening, you know very much about the context you're in. You have lots of experience in the communities that you're working with, and so collaboration between researchers and practitioners is essential. And Matt has demonstrated that through his partnerships with UNICEF, CARE, WaterAid, Save the Children, CRS, World Vision, among other smaller local NGOs. He has worked in a wide range of WASH-related areas, including uptake, adoption, sustainability, health impacts, behavior change, school wash. Many of you out there have worked with Matt before in school wash, I'm sure. And also prevention and control of neglected tropical diseases, which is why he's here with us today. He has ongoing studies in a number of countries, and we're very excited that he's taken out part of his morning to present to us today. So welcome to Dr. Matt Freeman.
You all are the experts in this field, and throughout the presentation, I will be asking you some questions about how we can, what your thoughts are on how different evidence that I present convinces you or not about the impact of WASH on NTDs, and potentially what other evidence you would need and what other programs you see as critical potentially to inform that complementarity. So I think this was shown to you before. This is the list of the NTDs, or neglected tropical diseases, as defined by the WHO. And I've circled here some of the infections in the NTDs that we'll be discussing today. We obviously can't cover all of them. And the numbers that you see in the box, in the parentheses, are the disability-adjusted life years as defined by the Global Burden of Disease Study. And while some of these numbers are not as big as, let's say, malaria, which is here on the lower left side, the point is that these diseases affect the most marginalized and poorest populations in the world. And there's a impetus that we have in order to address the control of these diseases. And these diseases in particular will not be controlled or eliminated without the improvement of water, sanitation, and hygiene access. So why neglected tropical diseases? Why are they called neglected? Because they affect more than 1 billion people in 150 countries, and they're diseases of poverty. And they're diseases of poverty in that there's a limited water and sanitation access and limited hygiene practices. That includes both the household infrastructure and access to health services.
I have a problem here. And the earphones.
There is much less attention and resources to these neglected tropical diseases than to HIV/AIDS, malaria, and tuberculosis, which receive a huge proportion of the global budget for infectious diseases. There's less funding compared to other diseases with less burden, as shown by this graph from Science magazine. There's $13 million for other diseases and $173 million not allocated to one disease. Another critical aspect of NTDs is that there's co-infection with other diseases. Some NTDs cause vulnerability for other diseases. So preventing schisto could also prevent HIV/AIDS due to the transmission biology of HIV. Schisto and intestinal worms cause anemia, and co-infection with malaria can be especially problematic when you have co-infections between schistosomiasis and other intestinal worms, specifically for pregnant women who are more likely to be anemic and also cannot be treated with mass drug administration when they're pregnant in the first trimester. Intestinal worms and lymphatic filariasis may suppress the immune functioning, which could also impact the susceptibility and infection with other infectious diseases. There's evidence for these indirect effects on other diseases, though it's still scarce, and there's building evidence base to advocate for the control of a number of different co-infections rather than specifically targeting one infection. And as you all know, as WASH practitioners, WASH is a preventive health intervention, and in fact serves as a preventive approach for a number of fecal-orally transmitted, and respiratory illnesses. So I'm going to start talking about trachoma. I think that David Addis last week covered some of the biology of the diseases, but I want to just repeat and remind you all before we start talking about the evidence base. So trachoma is a bacterial infection with C. trachomatis, and it affects the upper eyelid. It starts in young children, and these repeated infections leads to formation of scarring in the inner eye and rotation of the eyelid. And young children, as young as 5 or 8, can have dozens of infections, and there's some evidence that about 88 to 130 of these infections can lead to early signs of scarring and trichiasis. There are 324 million at risk of trachoma, and 1.2 million are blind. It's the world's leading cause of preventable blindness. It's spread from eye to eye by flies, fingers, and fomites. I hope this sounds familiar for those of you in the WASH sector. The fly, it's passed along by flies, and these flies breed best in human feces. And so sanitation is a major control strategy for trachoma, as well as face washing. So the WHO roadmap, I think David mentioned this last week. The WHO roadmap maps the control of the neglected tropical diseases until 2020. And the Lancet, which is a leading scientific publication, at the launch of the WHO roadmap said that there are very few, though the WHO roadmap mentioned safe water, provision of safe water, sanitation, and hygiene, it came last in their priorities. And there were no specific targets or goals which were included in the context of neglected tropical diseases. Now, trachoma is one of the few NTD control programs that has a very specific strategy to include WASH in its work, rather than just mass drug administration. And one of the main reasons that the NTD control strategies should harmonize with WASH is that they have these similar communities. There's a need to prioritize how the drugs are distributed and look for increased potential funding and informed cost effectiveness. Specifically, to understand how mass drug administration and WASH can impact disease in a complementary way. So here's a quick graph to help you understand the transmission of trachoma. This came from the Trachoma Toolbox, which you were assigned to read for today. So we'll be looking at how the SAFE strategy, which includes face washing and environmental training, specifically access to water and sanitation, can reduce this transmission pathway, or target this transmission pathway. And just a brief note, I'm going to be presenting systematic reviews and meta-analyses. And those of you many of you may not be familiar with what this means, what a systematic review and meta-analysis means. And what it is it's a review of available literature to assess what has been found in terms of associations and impacts. And I'll be presenting a number of these systematic reviews to discuss impact and association between the WASH and NTDs. And again, I'll be requesting that as we go along, you think critically. Does this evidence convince you that there is an impact of WASH on the NTDs, and how your program in the WASH sector could be used to target the control of NTDs in the places that you work? So there was some previous work done on the evidence base for the F&E components of the SAFE strategy back in 2001. There were many cross-sectional studies found. There was two larger reviews called the Cochrane reviews that only look at impact randomized trials, and they found very few studies assessing the impact of interventions on trachoma. That doesn't mean that there isn't an effect, but just that there are very few studies that had been undertaken. Very little attention has been given to this complementary impact. So we conducted this review, and by we, I mean a team from Emory University, International Trachoma Initiative, and Children Without Worms, on the effect of water, sanitation, hygiene on the prevention of trachoma infection. We wanted to look for association between WASH and trachoma, and we wanted to understand what was being measured in the trachoma community in terms of water, sanitation, and hygiene. And that's shown here in this table below. So we found that we were looking at distance to water, water source type, water access, total water quality, water quantity, and water used for washing, latrine access, use, sanitation, education, latrine maintenance, and a number of hygiene components: facial cleanliness, face washing frequency, bathing frequency, towel use. These are some of the parameters or the measures that were being used. And so our next task was to understand how many of these met our criteria that had a measure of WASH and a measure of trachoma. And though we found 5,425 studies when we did our initial search, in fact, in the end, only 81 studies matched our inclusion criteria. So we looked at those 81 studies to find out what is the evidence of the impact of WASH on trachoma. This table shows the literature density of all of those parameters of WASH, which you can find here, against trachoma. And you can see this is cut, I think this may be cut off, but this says the 81 studies down here. And you can see the distribution. 50 studies looked at water, 50 looked at sanitation, and 55 looked at hygiene. And the reason that it adds up to 81 is because many studies looked at both or all three, both water and sanitation or sanitation and hygiene, and some looked at all three. And we actually found 441 estimates of the relationship between WASH and NTDs. WASH and trachoma, pardon. A lot of these studies were experimental studies, which means that they weren't randomized trials or impact evaluations using randomization. They were just associations using perhaps baseline characteristics. Now, this is what we call a forest plot, and I know this may be quite a bit to take in, but let me quickly explain what you're looking at here. You're looking at the association between sanitation access and, in this chart, C. trachomatis infection, and here, sanitation access, and active trachoma. So two different associations. Each of these smallly printed words is one of the studies that we found. And here is the estimate right here. Now, the dot in the middle shows the estimate and the lines show the confidence. Now, what you really need to know is this issue right here. This line of no effect, this vertical line that runs down each of these graphs, this shows no effect. Okay. Now, if the circle and lines are to the left of that line, that means there is an effect. There's a preventive effect. If it's to the right, that means it's a risk factor. So what we want is to see these factors that are to the left, and this will be throughout the presentation. Okay. Now, if you zoom in down here at the bottom, there is a significant association on the summary. So we took all of these studies and we compiled them together, and we found that there was a significant association between sanitation access and both of these measures of trachoma. So that means that we are confident that there is an association in the literature that provides evidence. And on the left side, you can see that this measure means 0.5 means that there's a 50% reduction in trachoma among those that have sanitation access compared to those that don't have sanitation access. So a 50% reduction here between sanitation access and C. trichomonas infection. Sanitation use, there were very few studies that showed the association between sanitation use and TFTI. And we found that though our estimate was lower or to the left of that line, there weren't enough studies to actually say that we are convinced that there is evidence of that association. And more studies are needed. There are a number of studies that we couldn't put into a forest plot that show other sanitation characteristics. And there's really inconsistent evidence between latrine use and trachoma infection, type of latrine, maintenance or cleanliness of these latrines, and sanitation education. You can see that there are very few studies available, which makes it very difficult for us to estimate the effect overall. What that means is that more studies are needed. In terms of water, we found no significant association between access to water within 1 kilometer and our two measures of trachoma infection. And you can see here, the reason we make that conclusion is because these red dots with their lines cross that vertical line of no effect. For other water access characteristics, such as access to water, type of water, total quantity of water collected, quantity of water used for bathing children, we found mostly protective effects. Although again, there were few studies in many of these cases, and also many studies that showed no protective effect. For hygiene, we looked at facial cleanliness, so whether there was a clean face and trachoma. And we found that highly significant and substantial association between all of these studies listed here. When we compiled them, the summary statistics is to the left of this vertical line, which means that there is a approximately 44% or 66% reduction in 56% reduction in the odds of trachoma infection and compared to those with a clean face compared to those that don't have a clean face. Other measures that are used within the trachoma community, ocular discharge and nasal discharge, also were found to have a significant and substantial association between those measures and trachoma. Other hygiene characteristics were mostly protective, though there were a number of studies that were shown to not be protective. We looked at issues around face washing frequency, bathing frequency, hygienification, soap use, towel use, and towel sharing. Now, remember that towel use and towel sharing could be major risk factors for trachoma because the bacteria, when that used to wipe one child's face, could then be used to wipe another child's face, thus spreading infection from one child to another. So here's my take-home message slide. What can the wash sector do in terms of trachoma infection? The evidence says that face washing is of critical importance for trachoma infection. Yet the wash community doesn't promote face washing typically. The wash community promotes hand washing with soap to prevent diarrheal diseases, but not face washing. And could the wash community develop or use available hygiene messaging around face washing so that when working in trachoma endemic areas or areas where there's lots of trachoma infection, that you can promote face washing alongside hand washing? It might be a very easy and low-cost way for the wash community, the wash sector, to have an impact on trachoma. The second to do for the wash sector is to promote latrine use as well as presence of latrines. Now, I know that you already do this, but it's of critical importance that not only do people have access to latrines, but the latrines are used. And the final thing, which also is already done from the wash sector, is to promote fly control. And there's a lot of work in the wash sector on promoting VIP or ventilated improved pit latrines in order to promote fly control. However, because of diarrheal disease and because flies can serve as a vector for diarrheal disease, but often, as many of you know, these fly control components of latrines are not functioning and often are not prioritized. Fly control is of critical importance for trachoma control because flies are the vector which pass the bacteria from one eye to another, from one child to another. So, for you, please use the chat window. What other wash approaches might be applicable for trachoma control? Please think about what other wash approaches might be applicable for trachoma control. What other hygiene messages could you include based on the evidence that I've presented that might affect trachoma in areas that you work? Please just take 2 or 3 minutes to type your answers into the chat window. About whether reduction in trachoma will be a strong indicator for the wash sector donors to fund hygiene and hand washing. I think that's a very important question and one that I may not be able to answer. I think that your classmates will be in a very good position to answer that question. They're the ones that may be working closely with donors. So I do know that USAID and DFID are spending quite a bit of money now on NTD control, as well as the Gates Foundation. And so being able to make the case that your work has complementarity on work being done for trachoma control might be a strong motivator for funding. Has a great point here that controlling of the fly breeding places might be a good place to start, and that might be better than sanitation services. I'm sorry, fighting fly breeding places for providing better sanitation services. Yes. So by providing sanitation, you reduce fly breeding places that could pass trachoma, spread trachoma. But also, actually, what I thought you were saying was fly control as well, or environmental fly control could be one way to prevent trachoma. Someone says that I think CLTS, it's coming quite quickly now, that CLTS plays an important component of fly control. CLTS CATS triggering approaches could be used highlighting addressing trachoma and hygiene prevention. Yes, a number of you might promote CLTS, and CLTS could be an important avenue for trachoma control. And some messaging around trachoma could be included in your CLTS trigger. Ahmed says, improved hygiene behavior can be applicable for trachoma control, NTDs. When you're promoting hygienic practices, informing your community partners on trachoma could be a critical hygiene message to promote. DC says, eradicate open defecation and flies will be eliminated or reduced. Yes, as long as the sanitation that you're promoting has strong fly control measures. Otherwise, the flies will go into the pit of the latrine and breed there. Berhan said to me privately, improve latrine quality using sanitation marketing. That's a great point. That many NGOs in the water sector are moving toward sanitation marketing rather than direct implementation of latrines. And by including supply side approaches for sanitation promotion that have strong fly control components, these sanitation components have strong fly control pieces, you could have a large impact on trachoma. Susan asks, has anyone seen a hygiene promotion manual that includes face washing? Susan, my answer to you is that the only hygiene promotion manuals that I've seen to include face washing are ones using the SAFE strategy that are targeted at trachoma control. And Stephanie points out that the Carter Center has a handbook, and in fact, that was one of your two assigned readings was the Carter Center Trachoma Control Manual. Okay, I'm going to move on. These are great comments, and I encourage you to continue to discuss online in the chat window. I'm glad to see that Shamim is going to include it now. That's wonderful. Okay, we're going to move on. In fact, the implementing the SAFE strategy for trachoma control. This was one of your readings. And again, I want to remind you the 3 different ways in which trachoma is spread: flies, fingers, and clothes and towels and sheets. The Carter Center focuses on all components of the SAFE strategy and is a leader in thinking through integrating the F&E components into the SAFE strategy. Now, from the trachoma toolbox that you have in your email box, and you should have at least reviewed for this class, they think of hygiene improvement in two different ways. One is through enabling environments, through policy improvement, community organization, income-generating activities, and institutional strengthening. And then they think of it in terms of promotion, both through access to hardware and hygiene promotion. So access to hardware could include water systems, sanitation facilities, and community cleaning equipment, while hygiene promotion includes hand and face washing, community cleaning promotion, individual towel and cloth use, and school programs. Now, this looks very similar to the hygiene improvement plans that many of you will have in your WASH program. However, I want to point out that there's an inclusion of face washing here, and individual towel and cloth use. So these are some of the slight differences between the SAFE strategy and the general WASH behavior change approaches. The Carter Center promotes a number of different target groups. So specifically around face washing, who carries out face washing? You have to target the children, the mothers, and possibly also fathers and older siblings. The secondary target is mothers and women in the household who collect water, and male heads who decide how the water is used, whether the water can be used for face washing. And also teachers and key women in the community. Teachers are important because I know a lot of you do school-based water, sanitation, and hygiene programs. And teachers can be an important behavior change disseminator for children at school to do daily face washing. A new area in the WASH sector that I'm sure many of you are aware of is this idea of hygiene, habit change through daily face washing, through daily hand washing, and in this case, face washing at school. This is being promoted in Asia, specifically the Philippines. And this could be an important factor or important component that you could use in your program to promote trachoma control, daily face washing at school. So I'm going to move on to our second systematic review of soil-transmitted helminth infection. Again, what are soil-transmitted helminths? They're parasitic infections transmitted via eggs and stool, and the most common ones are roundworm, whipworm, and hookworm. This is Ascaris, or roundworm, and what happens is the worms, these adult worms, live in the gut, and then they're excreted into the soil where there are fertilized eggs, and these fertilized eggs become cysts and end up back in the host's mouth and back into the gut, and this cycle continues. And each worm in the gut is a different infection. So some children have hundreds of worms in the gut. This is the transmission pattern for hookworm. Hookworm, the same thing happens. There's these adult worms in the gut here, and they're defecated onto the ground, but they become larvae, and these larvae are able to penetrate the skin, specifically in the foot. And then that penetration, that allows them to make their way into the lungs and then the gut of children. So as might be evident here, WASH is incredibly important, both sanitation, promotion, hygiene, and food safety, as well as shoe wearing. The global burden of STH, you can see that there are over 2 billion that are infected with STH. And these infections occur throughout sub-Saharan Africa, India, China, and East Asia. And here's a chart that shows the age distribution. And you can see, those of you that do school-based work, the peak of infection and peak of morbidity is among school-age children, children under 15 years old. I see that a number of people are writing to me privately some questions. I encourage you to please make sure that you're sending to everyone in order for everyone to see your questions, as I'm not able to answer all of them as we are going along in the discussion. So the main morbidities associated with STH are anemia, stunting, and cognitive impairment. Pregnant women are also more likely to have anemia as a result of hookworm, and heavy infection can really impact children's growth. There's been previous work recently on a systematic review of soil transmitted elements and wash and sanitation that found a 44% reduction or association with lower trachoma infection and sanitation, 36% or 37% less hookworm among those that have sanitation, and 22% less ascaris among those that have sanitation. In our study, we found a number of different studies, 57 of which looked at sanitation, 41 of which looked at water, and 38 which looked at hygiene. And as you can see here with this Venn diagram, 17 which looked at all of them together. And in this case, I'm not going to go through all of the forest plots with you. I'm just presenting the overall findings here in this table. You can see that at the top we have factors within water factors that are associated with STH. Those in green were found to be statistically significant. So you can see piped water use is associated with ascaris, trachoma, and treated water use with any STH show quite significant reduction, statistically significant reduction in the association between STH and water, handling, and source. Wearing shoes was strongly associated with hookworm. And in terms of sanitation access, we found very similar results to those presented earlier by the previous review. However, you can see that as part of this, there are still very few studies in each of these different domains. And so more research is needed for us really to develop our understanding of effectiveness and cost effectiveness for STH and WASH. This is a recent study that we had published looking at the effect of school WASH and STH infection using a impact assessment in Western Kenya, where we looked at 40 schools. Where we looked at 40 schools that looked at WASH plus deworming against deworming alone. So we're actually here looking at the effect of WASH, school-based WASH, on reinfection following deworming, which helps us look at the complementarity. And what we found was that for trachoma and hookworm, there was a suggestion of an effect, and this 0.82 means an 18% reduction in the odds, and this 0.8 means a 20% reduction in the odds. So some suggestion that there's an effect, but we didn't have enough statistical significance to say that there was a statistically significant effect. However, for ascaris, we found a very large impact. So a 46% impact on reduction in ascaris reinfection in schools that received, 44. I did my math wrong. It's 44%. 44% 44% reduction in the odds of infection, comparing those that had WASH, school-based sanitation and hygiene, and those that didn't. So, what should WASH do? And the question is, what does the evidence say for us right now? We could say that it's important for the WASH sector to promote shoe wearing. After all, isn't this part of hygiene, wearing shoes? By promoting shoe wearing, the WASH programs could impact hookworm infection. Again, promote latrine use as well as presence of latrine, specifically at schools. Those of you that work in schools know that you can build school latrines, but there has to be a lot of behavior change associated with school latrines in order to educate children how to properly use latrine so that they don't go off into the field to defecate. And also promoting hand washing prior to food preparation. I don't show evidence here on that, but oftentimes we do a good job of promoting hand washing with soap after latrine use, but maybe not as much around food safety. And food safety is a critical concern when it comes to helminth infection. So, questions for you all. Are you convinced that improved WASH can reduce helminth infection? And do you think that there is additional evidence needed? Please use your chat window. Said privately that we have to be careful not to promote too many messages. Can you talk about how to combine and promote without overwhelming? It's a very important point. You don't want to overwhelm people with messages. In my experience, it's not very useful to promote behavior change using a health message. It's actually much more important to find out why, on a social level, people will do certain things for privacy, for pride, for self-efficacy, for safety. So I think it's important for the WASH sector in general to promote not based on disease or health, but to promote based on other factors. And by promoting those activities, you can promote, for example, hand washing and face washing at key times without actually overwhelming people with the reasons that they need, the health reasons that they need to do it. But finding other reasons that might be more motivated may make it less overwhelming. Birhanu says, yes, I'm convinced, but it should be integrated or coordinated in a manner with NTD control, which is much lower or non-existent. Birhanu, that's a great point. And that's one of the reasons that we're doing this course, is to educate the WASH sector about NTD control. The WASH sector is much larger than the NTD sector. And oftentimes, the WASH sector is able to work on their programs independent of disease outcomes. And I think it's important for those in the WASH sector to know where NTDs are endemic, so that when they're working, they can call up the NTD sector actors, stakeholders, and work with them to advocate at the government level about joint targeting of programs. I'm seeing a lot of great comments here about behavior change, messaging, and hygiene promotion for the control of helminth infection. I want to point out that many of these, the two diseases that I've talked about so far, trachoma and STH, are highly endemic among school-age children, STH even more than trachoma. And it's very important to recognize that your school-based promotion programs can have a great impact on both STH and trachoma by harmonizing messages with the NTD sector. one of the reasons is that as David Addis talked about last session, mass drug administration for STH in particular is done at the school level with the Ministry of Health. So harmonizing your behavior change approaches with the Ministry of Health visit to do biannual mass drug administration could be a very important way that you can harmonize some of these approaches. So I'm going to move on to schistosomiasis, and I want to remind you about the life cycle of schistosomiasis. There's two types of schistosomiasis, urogenital, and which is called schistosomiasis hematobium, and also schistosomiasis mansoni, which is passed through the feces, similar to soil-transmitted helminth. The difference between schistosomiasis and soil-transmitted helminth is that there is for schistosomiasis hematobium, there is a snail host where the schistosome egg there's urination and there's miracidium that are produced in the water, and those miracidium end up in snails that then produce cercari, which then penetrate the skin. So you have a cycle here: urination to snail population, snails to humans. So this is spread, unlike with STH, some of the key factors associated with schistosomiasis are key exposures are not eating contaminated food, or in the case of trachoma, sharing towels. In this case, it's actually walking in water. And when do people walk in water? Well, they might walk in water to bathe, and they might walk in water when they're doing cleaning of clothing, or actually during water collection. So the main exposures are when there's water collection from an unimproved source, and when there's bathing at an area where there is snail population. What should WASH do for schisto? Well, obviously you're already promoting improved water supply, but that's the thing that's of critical importance here, specifically around aspects of not necessarily just drinking water, but for water collection, for bathing, for washing of clothes. I just want to point out this is different than the other NTDs, the STHs and trachoma that we've been discussing. Education on risks associated with bathing and water collection areas where snails. And also the evidence for other WASH interventions is less clear. So Hale asked, is this common in coastal areas? Yes, this is common in coastal areas, though it's not, though the snails aren't present in salt water. Someone can correct me if I'm wrong about that, but I don't believe they are. So questions for discussion. Should WASH programming focus on schistosomiasis control? And now what about the control of the other NTDs? There's some very important points being made that WASH already does many of these activities that I've been saying WASH needs to do, that WASH should do. And that's the point. The point is that the WASH sector doesn't actually need to change the programming content very much, perhaps changing of issues around face washing and towel sharing, an increased focus on fly control, education around bathing and water collection in areas where schisto is endemic. But the messaging and the infrastructure is not all that different. What's important is that the WASH sector works with the NTD sector to complement the ongoing work that the NTD sector is doing, geographically complementing them. Also in terms of policy, that the NTD sector and the WASH sector work together in terms of advocacy at the national and district levels. Susan asked an important question. How do you avoid recreational use of unsafe water bodies? Susan, that is something that I really don't know. I think it's a very difficult thing to tell people to avoid recreational use of water. Sahel asked, hygiene messages for Schisto will be more focused around water safety. Yes, it's more around water handling than it is around consumption of water. Susan said, I saw one intervention with a swimming pool. Yes, there has been some promotion of swimming pools in Ghana specifically and other areas of West Africa. But I agree, it's a very hard sell to a wash donor to have them promote a recreational swimming pool. Okay, I'm going to move on because we're running out of time. So the last one that I'm going to talk about is lymphatic filariasis. And this is an ongoing study, not of infection, but of actually morbidity control associated with lymphatic filariasis. To remind you again, lymphatic filariasis is also known as elephantiasis, and it affects nearly 1.4 billion people in 73 countries are at risk of lymphatic filariasis, and 120 million people are infected, with about 40 million people disfigured and incapacitated by the effects of LF. And LF results in an altered lymphatic system and abnormal enlargement of body parts, causing severe pain disability. Birhanu asked, I'm just going to go back for a second. Birhanu asked, is there any study which shows the relationship existing of hygiene facilities, especially shower, bathing facilities with Schisto? Yes, there has been some studies, specifically in St. Lucia, but about maybe 20 years ago. But there have been a number of studies looking at the promotion of bathing facilities and schistosomiasis control. There currently has been some work going on in Zanzibar in Tanzania also, looking at the eradication of schistosomiasis using a number of different hygiene promotion activities. Okay, so back to lymphatic filariasis. It causes disfigurement, and there is the infection with LF is through a vector, through flies, and interruption of transmission can be achieved with antibiotics, as well as mosquito control. But the important thing is that morbidity management strategies focus on preventing infection and reducing the swelling, and that can include regular washing with soap and water to prevent infection, as well as activities such as elevation and exercise. So we conducted our systematic review looking at the association between morbidity management and lymphatic filariasis. And we found 12 studies, which we have not analyzed yet. These are impact studies that looked at the impact of lymphatic filariasis about wash in the control of symptoms around LF. So I want to talk about, moving on, I want to talk about the second reading that you had around Save the Children's School Health and Nutrition Program. And I want to just highlight them as one of the NGOs that I think does a very good job of integrating WASH and NTDs. And they do that through this rubric of school health and nutrition. They don't have a WASH team and they don't have an NTD group. They focus on the outcome of school health and nutrition, and they do that. Their goals are to keep children in school and to improve learning, and they use this multi-pronged integrated approach, increasing use of health and nutritional services, i.e. the control of helminth infection, increased access to WASH, skills-based education and policy change. And they also collaborate with a number of NTD control programs and partners as part of their work. And when they work in a school, they guarantee continued access to mass drug administration for helminth infection if helminth infection is endemic, and they also work on other control programs. And in the document that you saw, it highlighted a number of different programs, and I just want to say most of these country programs included deworming along with WASH at primary schools, which is a key area, a key nexus for integrated programming at the schools. But they also talk about a number of other studies in Mali, Bangladesh, and Malawi that looked at integration between different infectious disease control programs such as malaria and WASH. In Bangladesh, they looked at a multi-nutritional program that included deworming and WASH on nutritional status and growth. And in Malawi, they looked at provision of water storage containers for hand washing for a number of different outcomes. So the point here is that by using this rubric of school health and nutrition, they're able to work complementarily between the different sectors. So here's our final question for discussion. What are the advantages of an integrated control program in your country, and other disadvantages? What kind of activities do you think you could do to promote an integrated control program of NTDs in conjunction with WASH? So evidence suggests substantial impact of sanitation on trachoma and SCH, and there's some evidence to which water or hygiene-related interventions may reduce trachoma. There's some evidence for impact on schisto, specifically around water supply, but the programmatic implications are unclear. And there are actually few experimental studies, few impact assessments for which to draw causal influence. So I'll wrap up for now and add some acknowledgements for some of the work that was done for SHARE, the UK DFID, Children Without Worms, and ITI. And thank you all very much for your attention and for sticking with this presentation. I'll hand it back over to Kelly.
Thanks very much for that excellent presentation, and thank you to all the participants who have contributed great questions and comments. And as we did last time, we're going to put all your questions together and try and address them, especially because with this webinar, there's not always time to adequately address each one of your important questions, so we want to be sure that that's part of this course. And like we did last time, Stephanie Ogden and a few other people stuck around and had some good discussion. So many of you, it's very late, so we understand if you need to sign off. But for those that have a few extra minutes and would like to stay on and continue discussion or asking questions, feel welcome. Otherwise, our next module is in 2 weeks on November 19th. And please feel free to email me if you have any questions about the assignment or any other concern. So thank you once again to Dr. Matt Freeman and to everyone who is joining us from all over.